Welcome to the InTouch Health webinar series. This is Rachel Gonzalez, and I will be your host for this webinar. Today we will be featuring Greg Brallier of InTouch Health as he presents on the best way to evaluate whether to build your own telehealth network or buy one from a telehealth provider. Greg Brallier, Vice President of Technical Services at InTouch Health, has led the design, installation, configuration, and administration of InTouch Health's private cloud network since its creation over 10 years ago. He also leads clinical data integration solutions, HIPAA compliance, and InTouch's 24/7 technical support function, which provides instantaneous support to all platform users. His background includes developing and implementing database architectures and schemas for remote monitoring of computer-driven devices. He received his Bachelor of Science degree in Computer Science from the University of California, Santa Barbara. We will begin our webinar shortly, but first a few notices. You all have been auto-muted. If not, please make sure you mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. During the webinar, you will be able to enter questions in the Q&A widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website, and a link will be posted at the end of the webinar. This webinar presentation should last about 60 minutes, including time for questions and answers. And now, without further ado, here is Greg Brallier.
Well, thanks, Rachel, and thanks everyone for joining the webinar today on how to decide if you should build or buy your telehealth solution. My name is Greg Brallier. I'm the Vice President of Technical Services for InTouch Health, and I'll be your host for the next 20 minutes or so. So I wanted to take just a minute to go over what today's agenda will be. Start with a little bit about who I am and why I'm here today talking to you about telehealth. Then I'd like to spend a little bit of time on talking about building versus buying telehealth. When I refer to build, I know that when you build, you can actually buy many components and assemble a telehealth network. What I'm referring to is maybe buying or partnering with a company like a managed service provider for telehealth to provide the solutions for you. Then I want to spend probably the core of what we'll go over today on the my 6 key principles for what I consider when building telehealth networks. And then at the end, I'd like to circle back and have you look at your proposed solution, compare it to the 6 key principles, and see if it passes the test for a comprehensive telehealth network that scales. So just a little bit on my background. I'm one of the co-founders here of InTouch Health back in 2002, and we started providing telehealth products and services for our customers. I'm one of the principal architects of the InTouch Telehealth Network, and I've had experience in deploying over 130 networks for our customers in the past 15 years. I was also with our founder, Yulin Wong at Computer Motion, which merged with Intuitive Surgical. And it was there that I supported and we developed the first robotic surgical telemedicine procedure. It was called the Lindbergh Surgical Project. It happened on September 9th, 2001, and it was the first transatlantic surgery. We had a clinician in New York remove the gallbladder of a patient in Strasbourg, France, using ATM lines. And it was through that experience that our CIO and founder, Yulin Wong, started to visualize InTouch Health and how telehealth could benefit our customers and patients worldwide. I got my computer science degree from the University of California, Santa Barbara, where InTouch Health is headquartered here. I also am certified as a local area network administrator through UCSB as well in some postgraduate work. So I'm looking forward to sharing my experiences with you today. So building versus buying a telehealth network, the analogy that comes to mind for me is building a car. You could certainly go down and buy the components to build your own car, kind of learning as you go and maybe making some mistakes before you finally come up with a solution that would work. Or you could go down to the dealership and you could buy yourself a car that leverages the car manufacturer's best practices, quality systems, and you would have it today. Similarly, in telehealth, you could partner with a managed service provider for telehealth and have those services and products faster and cheaper. So I'd also like to emphasize that telehealth is not video conferencing, and it's more than just the remote provisioning of healthcare through telecommunications technologies, but it also includes the ability to treat patients as if the providers were in the rooms or in the clinics with those patients. Some of the tools that you'll need to think about as you build your network, you are going to need some telecom equipment, whether or not you assemble it yourself or purchase that equipment. You're going to need peripherals on the patient side, depending on the use case of your network. You need to also consider the availability and reliability of that network infrastructure and consider the acuity of the situations and service lines that you're servicing. Highly acute systems are going to need to be highly available. You're going to need to be able to support and maintain those programs, whether it be hardware, software, or human resources. Creating clinical workflows, what happens when the patient presents, how do you contact that remote physician and get him to the bedside for the consult. There will be ongoing training, and then there are consulting and legal fees that will be involved. Contrast that with maybe buying it from a vendor or a managed service provider to telehealth, a little bit like the automobile manufacturer that has already learned all the lessons and leverages the power of the network that they've already created. So let's really get started, and let's take a look at the 6 core principles and considerations that I use when I'm building a telehealth solution. Principle number 1, telehealth is global. I know that this seems obvious at first blush, but I'll spend some time explaining why maybe it's not quite that obvious. If you didn't document it, then it didn't happen. I think we all know that clinical visits need to be documented, but there are challenges in telehealth when the systems that you document on are not your own sometimes because you're part of a disparate network and you're reaching out to other systems. Principle number 3, and maybe a little cheeky, a picture is worth 1,000 dictations. I don't want you to forget when you're putting your solutions together for your various service lines, some of the use cases will require access to CT images and to MRIs. Again, there are challenges there, and we'll discuss those. Principle number 4, use the right tool for the job. Again, depending on your use cases and service lines, you most likely will need access to peripherals that reside on the patient side. So how do you see images from those, or how do you use the data from those and get those to the provider side? Principle number 5, you can't manage what you can't measure. This section is going to talk a little about key performance indicators, data, and metrics gathering that you can use for your analytics. And principle number 6, security is paramount. So when designing your solutions for telehealth, you're always going to need to keep security in the back of your mind. So let's get started. So principle number 1, telehealth is global, and I sub-bulleted with thinking outside the WAN. Truthfully, really all of the other core principles that I'm going to discuss today fall within this one. And really the challenge here is what telehealth sets out to do is connect providers and clinicians to patients anywhere in the world at any time. That really is the goal. I think what I notice sometimes happens with some of the groups that I consult with is that they're often focused on their immediate wide area network or local area network. In other words, the four walls of their institution or the networks that they control. I've also noticed, and many of you probably have as well, that IT is getting tapped on the shoulder quite often to stand up telehealth because there are technologies involved. And so what I've learned, being an IT person myself, is that I sometimes have to take a step back and remember that I need to look at the big picture. And what I'm speaking to specifically here is the image on the left shows really maybe a typical scenario where there's one hospital or a myriad of hospitals that an IT group would support. That hospital itself has a myriad of tools that you'll need access to for telehealth, some sort of audio-video session. You'll need to document those records. You'll need access to imagery, patient-side peripherals. And when they all reside within the walls of your wide area network, it's fairly easy to control access to those. You can grant physicians from any of your hospitals, 1 through 5, access to those applications, and even some outside doctors through maybe dial-up VPN type connections to get in. So I think where the challenges occur here is when you're providing telehealth services outside of your wide area network. Oftentimes, I think as an IT guy, I can spin up another MPLS line and connect to that location that I need to service, and I can install the telecommunications equipment there. I can work out how I might access those medical records by maybe VPNing in. But I think as you start to scale for growth in that model, you realize pretty quickly that, as I get to Hospital Z, the cost associated with MPLS lines and leased lines, sometimes the reliability issues with VPN connections, it makes it challenging to scale. So this is what I mean when I say to think outside the WAN. Not only do you need to think about getting access to those people, but now how are you going to support those facilities where you don't have IT resources, human resources there to service the equipment, and also the equipment itself, what you're going to need to install there, whether there be firewalls and gateways, if they'll even let you. Remember, this is not your network now that you're servicing. And what's your model for after hours and weekend support at those facilities? So in this model that I'm describing here, it's really trying to grant doctors from your hospitals on the left access to outreach hospitals on the right. But you have to remember that there may be other models of telehealth where you want to grant doctors outside the network access to all of these facilities. Maybe there's a shortage of a certain type of doctor for a certain service line, and you're contracting outside the network. So you have to keep that model in mind as well. The remote site infrastructure considerations would be things like, what are my choice of telecommunications technologies and gateways? What firewalls and routers would I install there? Or could I get access to through the on-site IT folks? Would they allow me access to their networks? Because that is what firewalls are for. They're going to protect the outside world from someone coming in. Also, when building, and this again depends on the acuity, but you want to have a telehealth network that is redundant and that fails over. You are going to need access to that when you need it, especially for service lines like stroke, where the doctor gets the page and that equipment needs to be available right then. Do you have 24/7 support staff to address those issues after hours or on the weekends when they're not up? And then maybe some of the not so obvious things are technology refreshes and software refreshes. Who is going to be putting new hardware in 3 years in maybe, or addressing vulnerability issues and remediation? The technology status monitoring and alerting on all of those equipment that is not, again, within your infrastructure. And then access control and provider licensure. Remember, we're talking worldwide global access now, across state lines, across country lines. Are your doctors provisioned? Are they licensed within those states? And how do you control access to the myriad of endpoints that you're going to be deploying? So let's move on to principle number 2. If you didn't document it, it didn't happen. The challenge here comes when documenting clinical visits, when electronic medical record systems differ between the provider and the patient sides. We talked about that a little bit with principle number 1. The issue here is that the doctors who are providing care for the patients and documenting that have a need to get the records from the patient side. Remember, the patient presents either, let's say, at an outreach facility. They have their own electronic medical records where they're documenting there. And then the doctor who is remote and does not have access to those systems needs to be able to document or share documents with the clinicians at the remote site. One way to solve this problem is using some global or cloud-based documentation system that allows all providers and all patient-side clinicians to document in the same location. And then after the interaction, maybe when the clinical note is signed, you can redirect that note in a myriad of different ways. It could be done maybe through fax, or the preferred method typically is through some data integration projects that take that cloud-based medical record and copy it to the provider side. Remember, the patient side already has the document because that's where the patient presents and where the clinicians are originally documenting. Even things like ADT integration on that side or ORM message integration can be done such that it's automated for the patient side clinicians and automatically gets copied up maybe into the cloud, and then the doctor merely annotates or documents on that as care and then signs that note. So some of the things I think about when those considerations become challenges is obviously EMR access. One of the ways you can do it is to give that remote clinician access to the site where the patient presents. That doesn't typically scale super well if you're doing 10 to 15 different sites, and now that doctor has to remember a myriad of different passwords or VPN connections to get in. Another thing to consider while you're doing this, as we mentioned earlier, is the data integration projects through maybe HL7 or FHIR interfaces. Those of you who are familiar with those, they're just a means of getting the disparate data elements from the patient side records to the provider side records. So it may be Epic on one side or Cerner on the other or Meditech. How do you share that? And one way to do that is through the HL7 FHIR interfaces. There are simpler ways and cheaper ways, but they typically are not as robust in terms of getting all that data into the records. Provisioning for digital signatures is also a big one too. So when that doctor signs the note for care, that can't be undone, and you need to think about how you're going to provision digital signatures, either through the EMRs, which typically don't always support that, or through another system that then validates that that doctor was the one who signed that note, and then you distribute it through the data integration projects. And then, again, how are you going to handle ePHI and security? Now you've got private or patient health information that's being shared maybe in a cloud-based scenario, or how is the doctor going to access that, and is he licensed and credentialed and have the ability or the permissions to see that remotely? So let's take just a second to visualize principle number 2. Again, this is our diagram from earlier, which shows your sort of IT-controlled hospitals and then your outreach hospitals. And then the challenge that we're speaking of now is you've got these myriad of providers that could be inside or outside the network. And how do they get to those medical records? Is it individually each site, or could there be another mechanism like we mentioned before that allows the patient side clinicians and the remote clinicians to share documents and then distribute them post signing of the note? So moving on to principle number 3, a picture is worth 1,000 dictations. The challenge here is really remotely accessing radiological images like CTs and MRIs that reside on the patient side. Again, this one is really service line dependent or use case dependent. There may be some telehealth scenarios where you don't need imaging, but for neurology or stroke or maybe cardiology, the clinician is going to need to or have to see the CTs and MRIs. Now, these CTs and MRIs exist within PACS machines on the patient side where the patient presented. And so the challenge is here, how do you see those images when you're outside of that network? There are a myriad of ways to do this. There were solutions that I initially architected 4 or 5 years ago that created tunnels that copied the CTs and MRIs out into the cloud. And once they were in the cloud, then doctors could see them remotely. that model works. However, speed is an issue there. I think if you're, the size of some of these DICOM images can be, gigabytes and can take 20 to 30 minutes. And so if you're doing especially a use case like stroke, that's unacceptable to the users. They can't wait 20 to 30 minutes when time is brain. And so we re-architected our system to manage it in a different way and stream those images out. Now, how you architect yours will really depend on the service lines and what you need. So some of the things that I consider, obviously, PACS access. How are you going to get to the radiological images at the patient side? So you need to consider that. Image upload times, as I mentioned previously, is going to be an issue. So how, does it matter to you? It may not. Store and forward might be fine for you, but if it's for acute scenarios and service lines, then speed's going to be important. And then again, these are CT images, MRIs, and they are there's patient health information that's private in there. So how are you going to handle security on those when you're transmitting them, if you are, and storing them in other locations? So they need to be encrypted in transit and at rest if you're indeed managing them that way. So moving on to principle number 4, using the right tool for the job. The challenge here is specifically access to patient-side peripherals required from any telehealth service line. How does the remote clinician get access to patient-side peripherals like stethoscopes, otoscopes, maybe for maternal fetal medicine, things like ultrasounds? And so depending on what use cases or service lines you're standing up, there will be patient-side peripherals that will need to be accessed. And so how do you go about doing that and streaming maybe the images or the data that comes from those over to the doctor side? One way, I think, is some of the telecommunications devices that I've seen have auxiliary inputs that you can plug those devices into. Not all of those are encrypted, though, so you need to be careful there. I know here at InTouch Health, our patient-side devices have auxiliary inputs that the doctor can toggle between the audio-video session and the peripheral session so that he can see both. And at InTouch Health, we do encrypt those while we stream them. And if you record those on the patient side, then they are encrypted at rest as well. So some of those considerations for the peripherals are remote access to those peripherals for specific service lines like I just mentioned, and what technology choices for peripheral image transfer to the provider side. How would you get that image across or that data across to the doctor side? So you need to consider that. And then what is the security of that transmission from end to end, taking in mind that this is, again, EPHI that needs to get from the patient side to the provider side. So principle number 5, you can't manage what you can't measure. The challenge here is collecting data and analytics. It's one of the most important features of the system because you're going to want to know and be able to measure how many sessions you had and for what service lines and how many clinical notes were signed and how much care was given through your system. And you're going to want to import that and run some key metrics and key performance indicators on your side. I know that, so I learned this from early on in my career from a COO that I worked for that was a Six Sigma black belt, and he was constantly focused on process, procedure, and metrics. And it was good for me in my early career because I've always utilized this all the way through. And we built it into our systems here at InTouch Health right from the beginning. And so as you build your systems, you're going to want to account for data collection, either through a data warehouse or in some means so that you can almost create, if you will, like a Verizon phone bill that shows all the connections that happened within a month that were telehealth sessions, what service lines those sessions were for, what clinical data was collected in those sessions, maybe what peripherals were used, so that you can later analyze your business and determine how it's doing. So some of the key considerations for me in this regard, utilization data connection by locations, users, and service lines. The KPI and metrics that you're going to want to gather really on number of consults, speed and time to access the patient. I know that that's very important to understand how quickly you're giving care. If you're doing stroke, door to needle times for TPA administration. There's so many more. I couldn't list them all here, but I'm just giving you an idea of some of the things that you should be thinking about as you start to deploy outside your network or build your telehealth network, that data is key. So we've come to our final principle. I know I'm going a little bit longer than I'd promised, but I think we all know that security is of utmost importance. What I think, though, is sometimes not quite as obvious is providing telehealth services outside of your locations requires you to be responsible for the security and regulatory obligations. Remember now, if in the example where you're doing maybe community outreach or outreach to rural community hospitals, you don't own those hospitals, and so now all of those information security reviews and security questionnaires that you require your vendors to fill out, now you'll be responsible to fill those out. You're also going to want to check with your regulatory group and your risk assessment groups at the hospitals that you're working for as to whether or not you have FDA obligations. I know here at InTouch Health, we strongly believe that an FDA Class 2 clearance is required when for highly acute cases like stroke, where active patient monitoring and real-time care is being provided, maybe in ambulatory settings or clinic-based care. You could get by with an MDDS or a Class 1 ruling, but we are a medical device company at InTouch Health for that reason. So you're going to want to check with your risk assessment and regulatory groups on what their stance is. So some of the remote security regulatory considerations, obviously FDA, you will need to assess the security planning and vulnerability remediation at those sites. Because remember, now you're supplying equipment there. That equipment may need to be scanned for security vulnerabilities and what's your plan for remediation. And then possibly staffing for these information security questionnaires and agreements. I know here we've got a full-time staff that works on those for our customers, and they come in at a constant rate. Some of those questionnaires, and you know this as well as I do, are 100 to 150 questions. So you're going to need staffing most likely for that, depending on the scale of your network. And then also dealing with however you set up your networks, you're going to have to obviously encrypt all that traffic in transit for the private or patient health information. So referring back to our diagram and with an emphasis here on security, just wanted to point out again that you, in the case where you're installing your telehealth equipment in your network to outreach facilities that are not your own, that you are going to be responsible for the regulatory security compliance. And depending on where you host these solutions, if you've got data centers of your own, or if you're going to spin up data centers out in the world, you're going to be responsible for things like SOC 2 Type 2 reports, for NIST and FSMA security industry standard reports, and audits. So be aware that this is important, that now you will be responsible for those. So moving on to the last slide, and really wanted to thank you again for attending the webinar. Does your proposed solution pass the test? So take these 6 principles, look at what you're proposing now as part of your program, and I'd be glad to help you here as well. I've done several total cost of ownership spreadsheets for our customers, and I could anonymize some of those and share those with you. I can tell you that in most cases, it is 3 to 4 times more expensive to build it yourself than it is to partner and leverage what we've done here at InTouch Health. But I can share those with you, and I encourage you to create your own matrix. And really, what I build these total cost of ownership spreadsheets on are these 6 key principles. And so I look at what am I going to have to stand up in terms of the network, the peripherals, imaging, human resources to support these, and all of the topics that we touched on today. So total cost of ownership over life cycle, remembering that whatever hardware you install at those locations or as part of your program are going to need refresh. What features and functionality are you going to provide for the different use cases, maintainability, scalability, and support of your system, and then what competitive advantage, if any, you might have now in your region. So Rachel, I think we can look and see if there's any questions coming in, which I'd be glad to answer for you now. But here's my contact information. If you need to reach out to me. My phone number here is included in my email address. You can also get my contact information from the InTouchHealth.com website. So Rachel.
Thanks, Greg. Now we'll begin the question and answer portion of our webinar. Please make sure you get your questions in through the Q&A widget located on your console. So we'll give a few seconds for it to come in. So first question, how long can it take to build your own telehealth solution compared to going with a telehealth provider?
Okay, thanks, Rachel. That's a good question. My guess there is it's gonna vary depending on what you already got in place. And so, reviewing the 6 key principles again, have you applied thought already to what your interconnectivity might look like? How are you set up from a data center perspective, and did you want to do it cloud-based? So there's a myriad of things to work through. My personal experience is customers that I've worked with who have built it themselves. It can take anywhere from 12 to 18 months to really spin up a solution. And so I think that would be my answer.
Great. We have another one here. What role can XDS play in telehealth?
So it's a good question. So XDS being globally based sort of architecture, the explanation might be a little longer than probably we have time for in here. Maybe this is one we take offline,
sure,
and I could get that person's contact info. And,
yeah,
okay.
We'll do that. Another question, what are the cost differences between building it yourself and buying a telehealth network?
So I guess I can share numbers, right? The projects that we've worked on, I guess I won't mention customer names for now, but what we did is we talked to them about what it would be like to spin up sort of, for us specifically, an InTouch Health Lite network. In our case, we've got 11 data centers worldwide. That wouldn't really, I wouldn't expect a hospital institution to go to that extreme because we're servicing many customers. But to spin up maybe at least a minimum of 2 where you'd have some redundancy to support this kind of a network, those are the typical scenarios that I've done cost analytics on. And so it was about 3 to 4x more to do it, as I mentioned in the presentation, and specifically, I think it was running between $4 and $5 million to do a full-blown solution, whereas contracting, at least with us specifically, and I don't know about other solutions you might look at, but for our endpoints, the way we architect our system, our PACS viewer systems, and all the tools that we use, it was costing, over a 3-year period between $1 million, $2 million to use InTouch, where it was, $5 to $6 million to do that on your own, something like that.
Awesome. So it looks like those are the only questions that have come through. If you do have any questions that you weren't able to get into the system, please feel free to email us using this email on the screen now. And we'd like to give a big thank you to Greg for today's presentation. Please visit our website to find a recording of this webinar and a list of upcoming webinars in our series. Thank you so much.